Hello, this is Dr. John Kanellopoulos. I'm eye surgeon practicing in Athens, Greece, and New York City, New York. Currently the president of the International Society of Refractive Surgery, partner of the American Academy. And I'm very privileged to be here and share with you today some of the venues we've gone by to reach emetropia in patients post-cataract surgery. My clinical work was described, and I consult for several companies present on this first slide. I would first like to familiarize you with a very exciting technology. This is a reflection topography, much different than what we have been used to reading and using clinically for all these years. We've been familiar with the Placido disc-derived video topography, and then the tomography such as the OrbScan, the Pendicam. The Cassini is a different concept completely. As you can see here on this slide, on the right-hand side, you can see the projection LEDs that have different colors, and those, as you see on the right, are being captured as their reflection on the cornea. This is the first Purkinje image of these LED color lights on the cornea surface, with the exception of the white, broader spots you can see like so, and so and so, which represent the second Purkinje image of different lights being emitted and being captured on the posterior cornea surface. So these data are analyzed, and the algorithm of the device does ray tracing between any three given spots, which is a different principle than Placido, where the analysis goes from ring to ring to ring. So theoretically, a bias at a site centrally will be carried on to all that meridian all the way to the periphery, where here each given topographic value represents that calculated at the specific spot with the Cassini software. So it's a different concept. These are almost 700 spots being projected on the cornea, and we have had the privilege to work with this technology over the last 5 years, and I'll be happy to share with you some of the findings. We went ahead and evaluated, and this is a huge cohort of patients, 350 patients, normal patients, which were group 1, and these were patients that were candidate for laser vision correction. And then we evaluated another cohort of patients, group B, which were the patients who were candidates for cataract surgery. And by default, these were older patients. You can see here 59 to 73 years old, where the younger cohort of patients, the LASIK patients, had an average age near under 40. So we're looking at the younger and the older population, and we found out that in group A, the average axis of repeatability measurement with a Cassini, and this is 3 measurements for each eye of each patient, was 2.49 degrees. And you can see on the graph on the left how these axes panned out, and by definition, if you sum up the 34% and the 38%, more than 2/3 of the patients had with the rule astigmatism, and then the bell curve went through the smaller percentage to have random astigmatism, different axes. And if you look at the older group patients, the pre-cataract surgery candidates, you can see that the majority had against the rule astigmatism, underlining what we have seen reported previously, that in human physiology we start being built by nature with the rule astigmatism, and in our lifespan this switches over to against the rule astigmatism. There are several things in the study that I want to point out. I want to point out that the accuracy of these measurements, and we're going to see this in this next slide, of repeatability, are very important in the low astigmatic range, because most topographers and tomographers can be more accurate in high astigmatism. It's easier to pick a high mountain position than a small bump on the map. So you can see the remarkable accuracy on actual measurement repeatability in group A, which in my opinion is more impressive in the orange column, which is the lower astigmatic range, rather than the higher astigmatic ranges where the accuracy is still very strong, but less significant in my opinion. And again, you can see the same holds true with the older group B, where the astigmatism was imaged, and we saw previously that it's mainly against the rule astigmatism. And just to go to a clinical example, this is one of the LASIK candidates, and the beauty with the Cassini is that The blue line seen on the image here is the simulated K flat. The red line, dotted line, is the keratometric simulated K, the steep meridian. And the total cornea power is the orange, and the total cornea power comes from the anterior surface minus the posterior surface, which is calculated by the second Purkinje images seen there. And I think it's very important when we're talking about cataract surgery and toric IOLs, because we want to make sure that we correct with toric IOLs on axis and amount of astigmatism on the total cornea power and not just on the anterior cornea power, which the LensStar, IOL Master, auto-refraction, and our surface topographies up till now are used to be giving us. So this is, for example, a case, the 60-year-old female who was going to have cataract surgery, and the total cornea power is different than the anterior cornea power. So if we had placed the toric IOL based on the anterior cornea power, we would have been in error, and this would have been a refractive surprise, because there's a posterior cornea astigmatism that's a different axis, and it skews the total cornea power, even with the fact knowing that posterior cornea astigmatism is much smaller than the anterior and plays an average a small role in the total cornea power. So very compelling evidence that total cornea power is very significant. We have other ways to measure it. This is a validation of what we would get as a number with, for instance, a sine fluke-based device or an anterior segment OCT device. And we've reported studies comparing all three modalities together. So going now to clinical reality, we saw the diagnostics and how there's technology to help us get the numbers. What does that mean in clinical practice? And this is a study we have reported on mean age of cataract surgeries of 67. So there's a lot of young patients there, dropping the mean to a lower age. My average cataract patient in Greece is between 70 and 75. And you can see here that the mean postoperative cylinder is quite high. There's a cylinder up to the level of minus 275, and a significant number of these cases were treated with toric IOL implantation. Some of them, like this one, are keratoconic cases, and there we used a approximation of the astigmatism with the diagnostic devices. You can see the pentacam on the right and the Cassini numbers on the left, which in this case are in agreement. This is a new methodology we're using for very irregular corneas. We're taking the topography-guided suggested treatment from an excimer laser for the optical zone of 5 millimeters to help us calculate the amount of astigmatism in the axis of the toric IOL we will place in the eye. And these were the topography-guided cataract cases driven with the Cassini, and we can see the preoperative and postoperative astigmatism being significantly reduced. Compelling data that toric IOL implantation is a very effective way in achieving emetropia post-cataract surgery. It involves 65% of the patients that I do. It's the most common lens that I use for cataract surgery over the last 10 years. And we implant even astigmatic toric lenses for astigmatism of 1 diopter. I'm a strong believer, as we saw in the study previously, that I will correct even half a diopter of against the rule astigmatism, because the human eye is built to have some mild with the rule astigmatism, and thus, although for some clinicians this may sound like a hyperbole, I strongly believe that my target post-op is minus 0.3 to minus 0.5 at 180 degrees, or if you may, very slight with the rule astigmatism to be achieved with a toric IOL. And this is looking how femtosecond laser assisted cataract surgery with the goal purely to improve these outcomes has helped a little bit, especially with toric lenses. There's a publication from last year. And I'd like to close with a video showing our technique in using Cassini-driven, this is intra-op Cassini data with the TrueVision device. You can see here, this is the 3D heads-up display. We're marking manually this cornea that's going to receive a toric IOL. This is fascinating technology. And we can see right before we start our cataract procedure, we will have the Cassini data being fed into the TrueVision device, and that will help us place our cataract incision. And then following the capsulorhexis and removal of the cataract, it will help us place the toric intraocular lens on the targeted axis of the total astigmatic power like we described before. So this is an example of a manual capsulorhexis patient. Of course, you can do this easier with femtosecond laser and removal of this cataract with phakic emulsification. And I'm always very careful in my cases, use copious viscoelastic, removing the cortex, careful to protect the anterior and posterior capsule, polish the underside of the anterior capsule. And this is the precision optic Toric IOL, I think one of the best in the market. I like very much the haptics because they tend to have traction within the capsular bag in those early days that the lens is undersized to the back size, and thus reduce the chance for the lens to rotate in the early postoperative period. And this is matching the lens toricity to the manual marks, the blue marks, but you can also see that green line provided by the TrueVision that will help us line up our Toric IOL in vivo with our preoperative Cassini obtained data. Fascinating technology. I think that it only makes your life easier. Again, finishing up with this case. And as I mentioned, this is the #1 lens that I use as 2 out of 3 patients that I do cataract surgery receive a toric intraocular lens in pursuing emmetropy after cataract surgery, which I think in our days is something very easily to attain if one evaluates the preoperative data precisely and accurately. And again, you can see here the device shows you intraoperatively the Cassini data. The Cassini has captured also iris and limbal anatomical landmarks that are then identified by the TrueVision camera, and you have a identification. This is another case of the same concept. You have identification of that specific eye of that specific patient, reducing the chance of error of data from another patient to another patient, which is always an anxiety for any laser system. This is another case, pretty straightforward cataract procedure, and placing the toric IOL with having at the end of the procedure, you can see here we're manipulating the lens to bring it on axis with our manual markings, and then we have the confirmation with the Cassini-driven axis data on the TrueVision device to fine-tune the potential bias in the lens placement. I want to finish by pointing out that every 2 degrees of cycle rotation of the IOL, we will lose 8% of the toric value of that IOL. So that kind of underlines the fact that we want to be so accurate with the toric lens placement. 2 degrees displacement in toricity equal 8% less astigmatic value corrected. That's why we want to be extremely accurate. You can see me writing here 1 degree of toricity and how manually I will mark. And at the end of the case, I'll speed this up a little bit. We'll see this case finishing up with the similar example like before. So I thank you for watching this presentation. I hope I helped you familiarize yourselves with our methodology through the precision toric IOL, the Cassini as a validator on our preoperative toricity data for cataract surgery patients. And thank you very much for your attention.